Whoops, should not have mentioned the double. The hole's already there, just shove a tube into it, regardless of what it's for. Like, you don't see them in the ER. All these cases are not always mysteries like this. Let's bring in a mystery. We don't know what we're getting. We're getting a mystery. PITT, stop going to the helipad. I always hate when this happens. Going down. Before my mom passed, she was on hospice, but she didn't want to go home either. This is actually my hobby. Now that's likely a heat stroke. See, now you have to give the report again because nobody else heard it. Welcome to Dr. Taylor Reacts, the YouTube channel bringing you the most extensive and in-depth critiques of the PITT. Next up is episode 7. Let's go. That was such a sad episode.
Where are we now?
Got the VRI for a deaf patient in Central 12. Still waiting on PITT for baby Jane Doe. Central 6 is sitting pretty with his insulin drip, and the Westbridge diversions are kindly waiting their turn to sip our ours in our lovely holes.
You are some kind of savant.
Worthy of a race?
Just more of my love.
Well, enough of that.
I have a sexual assault victim in triage. I called PAR, so an advocate is on the way.
Okay, we'll take care of it. Dr. McKay, what's going on with your patient in Central 9? Isn't she good to go?
Oh, she was, but she decided she wanted to stay in the hospital now because she's in too much pain.
In our loud and overcrowded ED with more Westbridge cases arriving every moment, she would be more comfortable at home.
Your debrief is lovely.
Thank you. Would you mind helping Dana with a sexual assault victim who just came in?
Of course, sure.
So when a patient comes into the ER after a sexual assault, we have a dedicated nurse that is going to be evaluating this patient. SANE stands for Sexual Assault Nurse Examiner. So depending on how this case goes, I'm not going to be commenting too much on it because this is largely a SANE nurse evaluation, not so much an ER physician evaluation. Now, if there's trauma, if there's injury, that's different. A physician is going to see this patient, but the large part of physical exam is actually going to be that SANE nurse. I had one case, it was about maybe 2 weeks ago. So after the assault, the patient actually presented to an outside hospital. They didn't actually have a SANE nurse. And for that reason, they were transferred to our hospital. So I'm seeing that patient, the specialist, the nurse specialist, the SANE nurse is seeing that patient, and they're evaluating this patient. That particular patient got an exam and meds and everything else. But the SANE nurse is taking care of all that. So the thing with the PITT is how much are they going to have the attending do and how much is, the SANE nurse going to be doing? So the ER provider is still going to see that patient, but it's more so to make sure that vitals are stable. If there's like a laceration, something that needs closed, if there's something bad, like we're going to take care of. But if there's no acute emergent intervention in terms of trauma and wounds and laceration and things like that, the SANE nurse is going to be doing kind of the rest of it. When that patient's ready for discharge, the SANE nurse is actually going to come up and just be like, hey, patient's ready for discharge. We already got them this script and this script and this script, this antibiotic, prophylaxis, things like that. And then we're going to drop the discharge. So I'm likely not going to be continuing this case, just to give you a heads up, purely based on this is largely a SANE nurse evaluation. I'll be very specific on this. This is largely a SANE nurse evaluation. And for that reason, I want to leave that to any SANE nurse that is reviewing this. And we're going to kind of stick with the physician aspect of the emergency room.
Why don't you and I go see if we can't convince your patient to leave?
All right, I need to take care of a sexual assault victim in triage. One of you needs to hold down the fort.
You can call for a SANE.
On a holiday? It'd be ours. We're not going to make this patient wait. And since I'm the only SANE on staff...
Princess will cover.
Hey, you two better not be teaching her any bad habits. Come on. You ready, Doc?
Sure.
A SANE is a sexual assault nurse
Realistically,
examiner.
we're going to be a little
We
bit
do
more
forensic
sensitive in the
exams,
ER. We're
collect
not just
evidence, and
blasting
hand it over
this
to the
out
police
for
if a
everybody
report is
to
made. We also
hear it as
provide
they're walking
resources,
by. It's
support,
pretty
Sometimes
crazy.
even testimony.
You go to court?
SANEs are very valuable in a hospital, especially in ED. More nurses should train for it.
It's a not so subtle hint.
That's what my ER looked like last night.
Looks like this is the new hotspot, huh? And only getting hotter. Any word on what's going on with Westbridge? I got 20 on lanternflies.
No, nothing.
These patient passports have an interesting alternative use.
Yeah, because the patient passports are dumb.
She's in triage chair 2.
At least
Thanks,
yours.
Lupe.
Here's her intake.
Got it. Hi, Miss Miller. I'm Dana. How are you doing?
Been better.
Yeah. You're in a safe place now. I'm the charge nurse in the ED and a sexual assault nurse examiner. This is Emma. I'll be assisting.
And I'm Dr. Al-Hashimi. I'll be checking you for any injuries that need immediate attention. You can just call me Alana. I don't have any injuries.
Okay, that's good. We're gonna get a room ready for you. Meanwhile, Dr. Al-Hashimi's gonna ask you a few questions.
How long is this gonna take?
I can't promise an exact time, but we'll try to be as fast as you need.
Dana was so good with her.
Okay, Alana. Do you take any prescription medications? Just Synthroid, 1 tab a day. Okay, and any
For
allergies
hypothyroidism.
to medications? No. Okay, Dana will come get you when the room is ready, and I'll be back to finish your exam. Come find me when she's in a gown.
Will do. We're gonna use triage exam rooms 1 and 2 for this. It's the most private space we have away from the ED. All right, this can be a lot. You up for it?
Yeah? Yes, I'm good.
All right, let me know if you need to step out. Dr. Ellis.
Oh, no.
Oh, yes. Need the room. Find another place to lay your head.
Not even a 20-minute power nap? And my double's at 1:30. I'm
No,
tired.
we're getting Westbridge diversions. And chairs is insane. Didn't you see out there?
Ew, I did not come in through that mess.
Okay. Yeah.
People sleep in here?
Yeah, night shift doctors need rest, especially if they have to come in during the day. But today we can't waste the space. I need you to get me a stool on wheels and Esme for a turnover.
Now, my abdominal pain. Oh.
God, come on, you piece of shit.
Look.
Finally, she's trying that.
I'll be right back.
She can communicate like that. Keep going. Okay, Santos is clearly rushed. She wants to just do a CT scan. We did confirm the patient clearly understands writing, wrote something, and the patient understood. Given this, while you're at least waiting for a translator, sit down with a pad and paper and communicate with that patient. Seriously, Dr. Santos, sit down with the patient and communicate via writing. This is easy to do. Also, computers have Microsoft Word. I have wheeled computers. You have these little computers on these little stands. You wheel them into the room, pull up Microsoft Word, and I've literally communicated with patients that way. Literally typing on the computer, they'll type, and we'll just go back and forth. Obviously, it's different if it's like really sick patient, trauma patient. Like, obviously, there's situations for that, but you do what you can. I would say the VRI is not failing this patient. Dr. Santos is failing this patient. No good ER resident is going to do this at all. When you realize that the patient can understand your writing, get out a Word document on the computer. Something is better than nothing.
Right now, Jackson is on an involuntary psych hold.
What? That's not necessary.
He just needs some rest. He's been studying for the bar exam. We can watch him at home. So far, all of his tests look good, but Jackson has reported hearing voices. This could be serious.
Dr. Jefferson will come back and speak with you. He can explain more of what may be going on with Jackson.
And who is Dr. Jefferson?
He's from psychiatry, and he's excellent. He can explain next steps and answer all of your questions.
Javadi, why don't you take the Davises to the family room?
Sure.
Excuse me.
It's just this way.
have reached the Pittsburgh Neuroscience Group. If this is a medical emergency, please hang up and dial 911. For our address and office hours, press 1. To refill a prescription, press 2. To leave a message for the doctor on call.
Hi, this is Dr. Baran Al-Hashimi. I'm a patient of Dr. Fairgraves. I need to speak to him if he's on call. If he's not, I'll take his next available appointment. And please call me if he has a cancellation. Thank you.
So she stared off. This is actually the second time this has happened. Although it was quick, my concern, like she literally just kind of stared off for however many seconds. My concern at this time though is absence seizure, which it looks like this is. The issue with this is actually patient safety. If Dr. Al-Hashimi, for example, let's say she was in the middle of a thoracotomy or middle of this big procedure, a chest tube, central line, and you have an absence seizure where you just kind of stare off, you can harm the patient during the seizure. It doesn't matter if she's not shaking. The fact that, you know, she's hesitating, she has her seizure, that's 15 seconds, 20 seconds, whatever it is, who knows what the hands were doing if she's in the middle of something. Again, it's a patient safety issue. If she's having these on shift, and these are actually absence seizures, she should not be on shift. She should be going home. Just saying, a few seconds is all it takes for a patient to be harmed. If she is hiding this to work here today, it's messed up.
Like I said, you're more than welcome to stay down here until an inpatient bed opens up upstairs, but that can take a while. Sometimes days, even longer.
It's gonna be really noisy here and you won't get any rest. At home, you'll be surrounded by your family and be more comfortable.
It's your choice, Roxy. It's not that I don't want to go home, but...
Hi, Mom. Mom.
Lena texted me to come back. I figured I'd bring the boys. What's going on? Is everything okay?
Robbie, police officer, incoming trauma.
Yes, incoming trauma.
I'll be right back. We'll give you a chance to talk.
What if the mom doesn't want to leave?
Well, then she's gonna have to put up with us.
I can't imagine. Her boys.
Oh, don't go there.
I'm gonna see if I can grease the wheels, get her room upstairs soon.
Good luck. What is that?
Battle plan for a hall space is filling up fast. Police officer should be here any minute.
Yeah, well, as soon as you can, please. I need you to fix the VRI. Thanks.
Dr. Santos goes, I need you to fix the VRI. Hello, you've already demonstrated you can at least communicate via writing. Do that in the meantime. I don't understand what's wrong with Santos. In real life, she would have been sent home after just an hour or two into the shift. I've talked about that in previous episodes. I'm not going to critique that, the whole issue with the charting. She's jeopardizing patient safety at this point. Can't stand her. We are 7 hours into this ED shift and she randomly orders a CT scan or says she's going to order a CT scan. What happens if she actually needed an ultrasound? Pregnancy comes back positive or it's an ovarian issue. You know, she orders a CT scan, but the patient needs an ultrasound. There are quite a few studies that will tell you a patient's diagnosis comes from their history alone about 70 to 80% of the time. Think about that. You're getting a detailed history and your diagnosis comes from that 70 to 80% of the time. That is from numerous published studies. And then of course you add the physical exam on top of that and everything else. That's why it's so important to listen to patients. Santos is basically skipping that 70 to 80%. She's not getting the history, just going right to the CT scan. Even if there's a communication barrier, you can still get an abdominal exam in. If you have a septic patient, let's say they got dementia, let's say they're nonverbal, they're just like staring, that's their baseline. In some patients, you can actually push on the abdomen and you just watch them like, they kind of wince. They don't have to say anything. And so when I do abdominal exams, I'm distracting. I always distract the patient. So I'm talking with them while I'm doing the exam. And I can't remember if I've talked about that in previous episodes, but I'm always talking with the patient during the abdominal exam because I want the best abdominal exam. I want them distracted. I want to be able to push and see where am I truly eliciting pain. And you have these patients that are nonverbal and you're going for cues. You're pushing. Let's say you're pushing that right lower quadrant. Patient's 80. They got a white count fever, borderline shock. They're on fluid. You're pushing that right lower quadrant and you just watch them just wince. All right, male patient, they got a history. Obviously, there's a differential. You can put ischemic valve, you can put everything else on a list. That particular patient had an appendicitis. But the point here is that you can still do a physical exam. If I recall, she didn't do a complete physical exam at all.
Santos, I need you to pick up some more of these Westbridge diversions.
Sure, you want my firstborn too?
Maybe. Will they know how to suture?
Intubated neck wounds. That's not great.
Oh, this is gonna be a good
Diverted. Is
case.
there a trauma room open?
Trauma 1.
What's the story?
Okay, so now we're getting an EMS report coming in. Kind of a side note, I will say what I've noticed with this season, maybe in season 1 as well, is that we don't actually get very many radio reports, if not at all. In real life, EMS calls in, they have a radio report, they're saying, you know, what they have, the vitals, you know, they're gonna say, right out, we'll be there, we're right outside your door, we'll be there in 5 minutes, that kind of thing. You have a heads up what's coming in, you can get the room ready, that kind of thing. When they arrive, then they're giving you that EMS report. And so in this context, we get this radio report, you get limited info of what's coming in. In general, when that radio report happens, this is your chance sometimes to activate a trauma, to activate a stroke, a STEMI from the field, things like that. When the patient arrives, you get that report. Even if you have a transfer coming from another hospital or anywhere, EMS is still calling ahead. All they know here is that they're getting a trauma. Why didn't we know any more? Yeah, you get some basic details, but why didn't you know any more? I just kind of wanted to put that out there. Now, I will say on the other side of things, and the reason most likely that's the case, is I think we need to hear limited info, because if we heard everything, it would kind of take away from the suspense of the case. Looking back, have we heard an iHern go off and EMS radios in a report? I don't think so. They call Dana's phone sometimes, which can happen in certain situations. Absolutely. EMS will actually call the charge nurse phone. The charge nurse will be like, hey, I got medic 123, just make up a number. They just want to speak with a doc. And so, hey, this is Dr. Taylor, go ahead. And they're going to tell me what they have. And sometimes we either talk them through a few things or we give them some recommendations. But you still have an idea of what's coming in. You know those details. We just continue to keep seeing these radio reports, these EMS reports. Just a few tweaks that I would make to make this 100% realistic and 100% accurate. And I think the iHern is actually pretty lacking in season 2.
My buddy Officer Hero, high velocity GSW. He's getting harder to bag. Warehouse robbery gone sideways. 1, 2, 3. You guys wait here. We'll take care of him, I promise. Thought you left us already for the open road.
I miss seeing you in uniform.
You should see me as a flight attendant.
Do you do this intubation?
Under active fire, yeah.
Are you serious?
I go in with the team in case there's an injury.
It's badass.
Dr. Santos, let's make sure these lungs are up. Can you see the cords?
Yeah, it was a great view, but it was hard to pass after I cleared him.
Right, because the gunshot wound was lower in the neck.
Dr. Santos, what could cause respiratory failure in an intubated patient?
Check the
There are
tube.
a lot of possibilities.
Okay, so at this point, we know that it was a gunshot wound to the neck, intubated from above. We saw no blood in the ET tube. Patient satting 85%, becoming difficult to bag. But we learned that, you know, when he intubated, he had a good view of the cords. But once that ET tube was through the cords, it was difficult to pass. Probably because there's a hole in the neck. So the question becomes, did we actually look at that hole? They covered it, so they clearly looked at it. But at this point, the patient's still hypoxic. We saw blood on the bag, but not in the ET tube itself. I can tell you, the ET tube does look appropriate in terms of how much is left out of the mouth. It does not look buried either at all. Some TV medical dramas, you actually look at the ET tube and it looks like it is so far, you get like barely anything sticking out of the mouth and you're like, dude, they just intubated the deep right main stem. Like that's how far it is. Or there's actually a scene in the pilot of Code Black where the intubation itself, you saw like so much sticking out and you're like, they just intubated the mouth. Come on, guys. And so I will say the ET tube looks the appropriate distance. Now, if anybody's watching this and like, man, Dr. Taylor, that was very specific. Code Black, season 1. That's because I did a live reaction on that. I'll put a link at the end of this particular video, but I did a live reaction to Code Black. In addition, I did a live reaction to the Scrubs reboot. So I forget what season that was that they just released, if it was like season 9 or season 10, but the reboot, I did a live reaction to episode 1. And even though Scrubs is a comedy, I destroyed it for accuracy and for realism. Obviously, people don't watch Scrubs for accuracy and realism, But if you're gonna have medicine in there, medicine better be done correctly. Otherwise, it's gonna be critiqued by Dr. Taylor.
Dr. Santos, what could cause respiratory failure in an intubated patient?
There are a lot of possibilities.
Think dope.
Displacement, obstruction, pneumothorax,
All right.
equipment failure, good lung sliding, no pneumo.
Yes, dope, mnemonic, DOPE. Really surprised here to see this. It's great to see it. It's been a while since I've actually heard that term used outside of like, you know, training purposes. Generally, we do all these things, but we don't actually use that mnemonic anymore once you did it like long enough. But it stands for displacement. So within displacement, you have a few things. Is that ET tube right main stem that we talked about on previous medical dramas, where that tube is just buried? Is it right main stemmed? Is it is it in the pharynx itself? Is it kinked? Is it is it occluded by blood? There's secretions, there's clots, it's being blocked. That is that obstruction part of that. P is pneumothorax. So that pretty much goes without question. Is the lung collapsed? And that's why you're having an issue. That's that P part of it. E is equipment. And really, it could be any of the equipment. The ventilator would actually be one of the issues. Plenty more examples, but that's what that mnemonic stands for. Really impressed that they used it here. I love it. Come on, even under fire you should see that.
Okay, that is a transected trachea.
The balloon is sticking out. The ET tube is sticking out.
Bag.
But if you intubate again, won't it just come straight out the wound?
Yep, exactly. So we're gonna need another plan. Okay.
Fast down to 83.
It's retracted into
he's
the
not moving
chest.
in the air. Okay, I need a neonatal mask.
Neonatal?
Yep.
Transected trachea means the bullet literally cut the trachea in half. When that gunshot to the trachea happens, what can happen is that trachea basically like sucks into the chest. It retracts into the chest itself. When he intubated from above, the ET tube went through the cords, but it popped out the hole. Now, when I'm analyzing this for accuracy and for being realistic, this wound for accuracy and for being realistic, the question becomes, am I buying that the ET tube was clearly displaced for that entire EMS trip? And you had Dr. Abbott intubating. Like, he intubated, it went through the cords, popped out the hole, they covered it, patient's hypoxic. Yeah, you're under fire, but you still have that trip in. Am I buying that that happened? Absolutely not. Am I buying that he didn't recognize that? No, it's coming out the wound. He did intubate under fire, I get it, so plenty of distractions, but he was still with that team when they brought the patient in, when they were away from the area of fire. It is standard that when a patient is intubated and you're evaluating all of these things, you would have caught this sooner. I'm not buying it. Obviously, they just covered, the most likely to explain this is they just saw the wound, they covered the neck, didn't even bother, and then they intubated from above and didn't even bother taking the dressing off when the patient was hypoxic and had no lung sounds essentially. I'm not believing that series of events. Now the issue is, if this would have been caught sooner, either putting the ET tube directly in the trachea, like you see the hole, you see the trachea, and put the tube in, like you would have done that, okay? The hole's already there, just shove a tube into it. But I will say, what can happen in that situation is that the trachea is shredded. And when that happens, it can actually retract into the chest in certain situations. I'm calling this scene 100% not realistic. With the staff, specifically, with the staff that you had on this case, not catching it until the ER. Oh, but I know why. That's because we want to show off our knowledge of the dope mnemonic and not realize that the ET tube was displaced. Didn't even look. We didn't realize it was displaced until the ER. Yeah, I'm not buying that.
Where does it hurt?
Like here, under my belly button.
Okay, do you have any fever, vomiting, diarrhea?
No, it's just a stomach ache.
Okay, well still go see the nurse and have her call me.
Okay.
Pain under the belly button could be a lot of things. Appendicitis is still on that list. UTI is still on that list. You could put ectopic on that list. Pelvic inflammatory disease on that list. Cervicitis on that list. You could probably put diverticulitis. Like the list goes on and on. Put obstructing stone, kidney stone. The differential is huge. You could put a lot of things on that list. Ovarian torsion can be on that list, just to name a few. In the ER, we always think worst scenario case first. What is going to kill that patient first? That's what we're focused on. and then everything else is okay. We're going for the life-threatening thing first. So when I hear that abdominal pain, that's realistically kind of the differential. Obviously, you can add a few more things to that, but that's the differential we're thinking at that point.
But I'm still having ice cream tonight.
Let's just see how you feel later.
It's not bad. You don't have to get so sad.
Yeah, sad. I'm good.
Your face doesn't look good.
Well, you still want to watch the fireworks tonight? I have our headphones.
We're getting an EMS report.
Sorry, Becca, I gotta go.
Sorry.
These are the reports we talked about previously that are unrealistic. We keep seeing residents and attendings in the Bay getting EMS reports and wasting time. After they finish, guess what? That EMS report will then be given again to the nurse assigned to that case when the patient is in the ER. We see it for that, dramatic television appeal. Now, in a mass casualty incident, I'll say, you're in the triage area, they're in the triage area. Sure, this is appropriate because you're triaging them. When we get a bunch of transfers, we don't sit out in the EMS bay. We're getting like rooms ready. You're not gonna just be out there taking report and then they're gonna get, like EMS gonna give report again. It makes no sense. So with that being said, we hear a 17-year-old male had a syncopal episode at football practice. Without going any further, pausing here, the differential is huge at this point. Could this be pulmonary? Could this be cardiac? Now, he's outside football practice, it's hot, so could this be, this is heat exhaustion, potential heat stroke, development for heat stroke, rhabdomyolysis, so you get the elevated CPK. A lot of things here at this point. This literally could be anything in terms of underlying cardiac arrhythmias. You can put a lot of things on that list, not so much Brugada, but you could put HOCM on that list, so hypertrophic obstructive cardiomyopathy on that list, prolonged QTC. There's a lot of things that could do this. And so I say to students or residents, kind of keep that differential broad, common things being common. That differential is pretty broad, and then you're going to quickly narrow that down. So most likely in this case, we're dealing with heat exhaustion, but you still keep in consideration the potential other diagnosis. Realize though, heat exhaustion could be a red herring. Patient actually had a syncopal episode because they had a prolonged QTC, and they also happen to be exhausted. Heat exhaustion, everything else. Now, can those be related? Yes, because of electrolytes and things like that. But the point is, the differential is pretty broad. As an ER doc, you need to be careful though with this sometimes, because the obvious thing may not be the correct diagnosis, but sometimes the obvious thing can be the correct diagnosis.
Elliot Green, 17, syncopal episode of football practice.
Look, I just got dizzy, okay? It's hell week. I need to get back.
Yeah, okay, tough guy. ANO, systolic of 95, tachy at 122, no meds, no allergies.
How long were you at practice?
Started at 9, so like 4 hours.
4 hours in this heat with all that gear?
No pain, no game.
Honestly, solid EMS report. We just didn't need to hear it in the bay itself. 4 hours in, hot sun, football practice. I'm already thinking pretty severe dehydration on top of whatever this patient has. Obviously, you need a good history, you need a good physical exam. You're gonna get labs on this patient. Most likely heat exhaustion, but you still wanna rule out the bad stuff.
God, I'm hungry.
Why are these students always just sitting around?
Hey, when's our break?
There's no breaks down here. Always make sure you pack a protein bar, something quick.
Ogilvy, Joy.
Sorry, I had a rough shift last night, and I'm gonna go to
Jump in
town
on
on
this.
this episode.
Syncope at football practice.
I just needed to hydrate.
Possible heat stroke?
Well, with heat stroke, you would have an altered mental status.
And they're usually dry, not sweaty. Mortality is 50%, especially in the elderly. And in extreme heat like this, basically fine. If the temperature
Langdon, can you cover this?
No problem.
Mr. Diaz? Orlando, where are you going?
home. You take these out.
No, it takes 48 hours for you to get out of DKA. Your blood is still full of acid.
Look, I can't add thousands of dollars to the $100 grand I already owe.
I'm sorry, 100 grand?
It's a medical debt. My wife doesn't even know. I'll never be able to pay it off as it is.
Where are your wife and daughter? Maybe we can all talk.
I told him to go back to work a couple hours ago.
But the hospital is giving you a big discount. And Mr. Diaz, I know it's not ideal, but can you stay for at least 12 hours? It will get you out of the danger zone.
No, I really can't. Every minute I stay is a meal, shoes, school supplies. Plus, I have a second job I have to get to by 4.
You need fluids.
I drink plenty of water.
And potassium and insulin. Okay, how about this?
You stay and I'll get together everything you'll need at home.
This
Also, a
happens so
referral
much
to
in
Northside
ER.
Christian Health Center. Come on. You don't work until 4. It'll keep you from passing out on the job again. Or worse.
Okay, I guess.
Great. Thank you. Please.
I give credit here to Dr. Mohan. She's doing what she can to try to convince the patient to stay. It would be one thing if the patient was altered, if they were confused, but with his mental status right now, you can't force him to stay. If he wants to leave against medical advice, AMA against medical advice, and he at this point, I can tell you, he would understand the risk, decompensation, cardiac arrest, and death. Pretty much the 3 worst things that you can have, like clinical decompensation, cardiac arrest, and death. Maybe you can add like coma seizure in there as well. But the point is, he's not altered at this point. Now, when he first came in, he wouldn't leave AMA, right? He was slumped over, if I recall. But in this case, he would understand the ability, like what he's doing. He would understand that of what it means to leave against medical advice. Now, one of the most common, reasons I see in the ER for patients that want to leave against medical advice is they actually have a personal issue at home. Sometimes they'll talk about it, other times they don't, but they have a personal issue at home. It's a job interview, it's a job. They were, for example, last week before, I forget, but they were homeless. They just got an interview. They needed to go to the ER for something. And if they left against medical advice, they were going to be able to make their interview, but trying to convince them not to leave against medical advice. But they came there thinking they were going to get seen really fast, and then one thing led to another. The CT was a very life-threatening diagnosis. And so it's one of those where really talking with the patient, getting them to really understand the diagnosis and what that means. Like if they die, they won't be able to get that job. And so not that you're scaring the patient, but you want to be realistic. Like, hey, this is what we're dealing with. And sometimes that is greater than that personal reason. Other times, patients still end up leaving. Let's say it's not necessarily a life-threatening diagnosis, but it was a patient that you're like, I'm really concerned about, and you want them admitted, and they leave anyway because they had a funeral, or I've had one patient that left because they had a date that they wanted to go to, and then they end up coming back in afterwards. So there's a lot of reasons that patients leave the ER against medical advice, and I think I give Dr. Mohan credit here for trying to convince him to stay. I think this is huge. I think how she's going about it is good. And so I really have no critique with that. I just want to kind of pause because this is important, and it's easy sometimes to be like, all right, see ya. You're advocating for your patient's health. You understand what they're going through. And if they're honest with you and they tell you what you have, you got some ways around some of these things to really help them out. An acidotic patient like this that leaves against medical advice, you leave like this, regardless of him, not being in a coma. He may be acidotic, but obviously he's improved from what he was. A patient that leaves against medical advice like this, you're not going to come back the same. You're going to come back and this is going to be much worse. It's going to be a different situation. It's going to be far worse. That's what happens in situations like that. So again, mad props, Dr. Mohan.
That's up to 98. Neonatal mask is working. Santos, finish the test.
Yeah, what are you injecting?
Vita with Epi. It'll clamp off any little bleeders, some skin hooks. For Shiley? I don't like the curve of it, Shiley.
I didn't know you were so picky.
Santos, take a break. Help me cut down a 6-0-ET2.
What is going on here? You have a field medic assisting you?
Dr. Abbott
No
is
way.
an attending, and he's also a SWAT physician.
My buddy Hero here is in bad need of an airway. They cut it right here.
We can do this.
No, I got it. You must be Gloria's new hire.
Yes, Dr. Al-Hashimi.
Well, I'd shake your hand, but my tube is ready.
And if I could find it secure the distant trachea, we have a shot at this.
Okay, keeping an eye on the stats.
You don't need to do that at all. Just leave.
Slow is smooth, smooth is fast.
You can call me just to say hi sometimes. What's up now? GSW with tracheal transection.
Very retracted.
All the way in the chest.
I think I can get it.
Both lungs are up. Sats scanning the belly now.
Okay, I got it.
Man, that looks so realistic.
Down to 89.
I'm in, balloon up.
Should be a little bit more firm, but it's very realistic.
End tidal, excellent waveform.
Good breath sounds.
Also, the tracheal to the skin, 2O silk.
Sats are coming up. Ooh, not bad, Abbott.
While you were playing with that airway, you missed a big bruise in the left upper quadrant. He
No,
was
they
wearing
didn't. It's
body
airway
armor.
first. Come on now.
Projectile doesn't have to penetrate to do damage.
There's no fluid in the suprasplenic space.
Let me look. Okay, right there.
Looks like a subcapsular hematoma of the spleen.
Must have been a big impact.
AR-15 muzzle velocity is 3,000 feet per second.
CT angio of the neck ASAP, along with CT chest, abdomen, pelvis.
Yep. Just as soon as we secure this tube.
Oh, she likes him. What made this case difficult is because the trachea was 100% transected, literally, all right? It coiled into the chest. So when he intubated from above, it likely pushed that trachea further into the chest. So they had to find like the end of it and intubate through that. Now that's pretty extreme, and that's an airway that frankly no ER doctor wishes they would ever have to have, no surgeon wishes they would ever have to have, probably no ENT wishes they'd never have to have. Like, that is a sphincter clenching moment. None of us want that if we're being honest. Now, we just want their standard intubation, right? Normal patient, Malampati of 1, no history, airway is beautiful, ET tube slides in, the perfect situation. We don't want this airway if we're being honest. Now, I'm just not buying this entire situation in terms of what Dr. Abbott did in terms of intubation and didn't see the balloon sticking out. I just didn't buy that from the beginning.
First leader's in.
Mucous membrane's dry.
Pupils 4 millimeters reactive.
So what do we know so far? This 17-year-old's at football practice, long practice, multiple hours. He was hypotensive, he was tachycardic, he's got dry oral mucosa. We also know the patient passed out, so just like what we talked about previously, the differential is huge at this point. We definitely need an EKG. We definitely need blood work to include a CPK to make sure there's not any rhabdo. If there is, obviously he just needs a bunch more fluid. But the odds that he's in rhabdo is pretty high, at least a little bit. Just realize, regardless, that it seems like this is a straightforward heat exhaustion. This could be something else. Heat exhaustion, while it could be his diagnosis, could be a red herring. It's not the primary diagnosis. A patient with a cardiac arrhythmia can have heat exhaustion. Patients with a pulmonary embolism can have heat exhaustion, right? You don't want to get so narrow focused you miss the diagnosis. All these patients keep coming in. Yeah, you're gonna have heat exhaustion. Sooner or later, one of these is gonna be a heat stroke. One of these is gonna be a seizure. We're gonna see the whole spectrum of heat exhaustion. And so I really caution this. Don't get narrow focused, keep that differential, and realize sometimes the diagnosis that seems easy may not be the one, and vice versa.
Did you get tackled today?
No, just running drills.
Any chest pain, palpitations?
Solid question.
Hands off, please. Running the 12 lead.
How we looking? Good. Healthy kid. No history, no trauma.
Differential for syncope in an adolescent.
Cardiac arrhythmia from drugs,
Hypervolemia,
long
seizure,
QT, WPW,
sepsis.
or Brugada.
Brugada is more common in Asian males.
That still should be considered.
Long odds, sir. Brugada prevalence is 1 in 20,000 in North America, as high as 1 in 300 in Asia and the Middle East.
And?
Oh,
First
snap.
described in 1992, has a high incidence of sudden death among young patients with otherwise structurally normal hearts.
Wait, did you just say sudden death?
Temp is 1 in 2.5.
Sorry, our student doctors are discussing a rare condition you don't have.
I just didn't drink enough water. I overheated.
Not my type, bud.
Other than standard labs, what else to order?
The blank stare. Happens all the time.
CK to rule out rhabdo. To make sure you don't have any muscle breakdown from the heat.
Let's set up a cooling room for Elliot here in the other heat exhaustions we will inevitably get today.
When this patient arrived into the ER, he met SIRS criteria. He still could be septic. Now, they did ask great questions, including trauma, taking a hit. I love this. Now, I would have asked the exact same question. One thing I would have asked, though, is that, and I didn't hear it, is how did you feel before practice? That's a key thing. And I think sometimes in the emergency room, that's actually missed. Now, if they're like, doc, I felt terrific, I felt great. Obviously, that's one thing. It's just one question, kind of a little tidbit. And I'll probably, I have a shift later tonight, and I'll probably ask that question probably 2 or 3 times on this shift. Last night I asked it probably just a couple times. But that's pretty standard depending on the situation. And you're gonna be like, how did you feel before that happened? Like, did we have symptoms before that happened? I'll just keep putting these tidbits in here because I think with the rough night I had, there's a lot of things that keep going on in my head in terms of different parts of the PITT triggering those, which is always the weirdest thing because the PITT is so realistic, but even if it's not the same case, it causes you to think about other cases like nonstop. And so one of those could be, let's say you have a patient that comes in, they got body aches after working a 12-hour shift. That's all they complained about. They checked in, doc, I got body aches, nothing else. My body hurts. It's been a long day, but on questioning, turns out they had leg pain, right leg pain. They had subjective fever. They felt warm. And it turns out when you ask them like further about, they felt like that before the shift. Huh. So it wasn't the shift. The shift was a red herring or it got worse, but something happened before that shift. Now in the ER, they were febrile, 103, tachycardic, 140, 150. It was high, whatever it was, like something's going on here. Something's not right. They didn't have just symptoms after the shift. They had it before. So when you ask a little bit further, it turns out they've had this rash to the inguinal region, literally to the groin for 4 days. Turns out necrotizing fasciitis to the inner thigh. That wasn't even their main complaint. Nowhere in the complaint was rash or thigh pain. And it wasn't until you asked the right questions did you arrive at that particular part of the physical exam. Labs, imaging, surgery consult, they went to the OR, patient did awesome. The body aches were actually rigors, all right, of sepsis. That's what that was. And sometimes I will say patients are not the most forthcoming at all. And in this case, the patient just assumed body aches were the biggest issue. They worked all day, they had body aches. They wanted that addressed, but those body aches were really rigors of a much, much larger issue.
Thanks, Antoine.
No problem. Keep your head down out there.
What's the story? Neck angio is negative, missed the carotids.
It's lucky.
What about the belly?
Small splenic injury, no free fluid in the abdomen.
That should heal on its own.
What's the plan?
Head and neck will have an OR ready with thoracic standing by.
How soon can they take him?
We're a little backed up with Westbridge patients, but let's bring them up. I'll get them taken care of for you.
Like you got that neck fasc patient taken care of? They
You'll
lost
be
their
okay
leg
here.
because
We'll
of
get
delayed
you
care?
surgery. I'll write the procedure note.
Thank you.
SWAT, really?
I suck at golf.
You spend time in the Middle East?
More than I would have liked.
I worked in Kabul with Médecins Sans Frontières and in 2020 at the maternity hospital. I met the most incredible, bravest doctors there.
Vashti Barchi. Tragedy. We should grab a beer sometime, share war stories.
I'd like that.
Wow, chicka wow wow.
She seems cool.
Yep,
Oh,
maybe.
little do you know.
I could be around long enough to find out.
Oh, there she is. Vic!
Dad.
Victoria, this is Dr. Amy June. Dr. June is the smartest person
All
I
right,
know.
what specialty is she?
Just kidding. Seriously, don't.
Can't tell yet.
Hi, are you here to see a patient?
No, we're here to see you. Dr. June is chief of dermatology. And Victoria's
What?
first
You don't
shift
see
in the ER
dermatology
was
in
on
the ER.
day of the PITT Fest shooting.
I heard all the incredible stories, including your own acts of med student prowess.
Wow, med student prowess. That's. No, I'm pretty sure I was just trying to stay out of the way.
She's modest, like her dad.
And her mother? Oh, sorry. Dr. June. Yep, coming. I'm doing a favor for someone at the mayor's office who needs Mohs surgery on a basal cell carcinoma. And then I am grilling for 30.
Oh my God.
Happy 4th, all.
Happy
Yeah.
Thanks for coming down.
My pleasure. Let's grab a coffee sometime.
Absolutely. Yes. Thank you. You know, Mom really wants me to go into surgery.
Your mom wants me to stop drinking and join a pickleball league.
Oh, that's the same.
Yeah, well,
Exact same.
I still have not
Risk an
played
Achilles tear
pickleball
before I
before.
give up scotch. Hey, I hope I didn't embarrass you coming down here.
No.
I'm just trying to present you with some options for your residency.
I really appreciate it, Dad. I do. I'm still not sure.
Well, either way, you'll do what's right. You always do. Radia.
Dr. Javadi, you are a man of many talents.
You don't know the half of it.
Your daughter has some high standards to live up to.
No, you don't know the half of it.
I literally talked about this last critique. You do not see dermatology in the ER. 100% unrealistic. Now, in this case, it was because, Giavatti's dad wanted to introduce her to the dermatologist. That's why the dermatologist in here. I'm just saying that even in that situation, you still don't see dermatology in the ER. Last critique or the critique before, I talked about specialties that you just don't see in the ER. Dermatology is one of them. I've never seen a dermatologist in the ER, regardless of what it's for. Like, you don't see them in the ER. And I think out of all the, specialties to see in the ER that we haven't seen yet, it doesn't make sense to put dermatology ahead of them. Obviously, the PITT's trying to represent various specialties, trying to introduce them along the way. But if you show us specialties that you don't normally see in the ER, it becomes unrealistic. If you advertise yourself as realistic and then you show a dermatologist in the ER, that's crazy.
We now have a heat exhaustion treatment area in North 5.
Evaporated cooling. Great plan.
Yeah, what is Dr. Langdone's idea? He figured we'd be seeing a lot more patients in this heat.
He's right. How are you feeling?
It's a loaded question.
It wasn't meant to be. You have a deposition in a couple hours?
Yes.
How you feeling about it?
Trying to think positively, but feeling less so. This job's really important to me and my sister. I support both of us.
It's gonna go great. Just tell them what happened. You're not at fault. Your job's not in jeopardy.
I mean, the lawyer said that I could...
The lawyer's job is to try and shake your confidence. So don't let them. You're a very good doctor.
Deposition in a few hours. I will likely not be talking about this extensively, but I did want to mention, we keep hearing about this deposition. Now, I figured from the beginning it was going to be the measles case from last season, which would be a joke. It would be thrown out. Like, that's not a lawsuit case. Like, any law firm is going to throw this out. That's crazy. I review various medical malpractice cases for various law firms, and I can tell you this. This case would be thrown out so fast. After an expert witness, in this particular case, after an emergency physician reviews this case specifically. Now, you'll have other specialists in cases like this that, review this. But when an emergency physician reviews this case, they're going to give the recommendation to the law firm in terms of if they agree that was there negligence here, was there delay of care? Like, they're going to give a recommendation. And I can already tell you this, a case like this, ER doc would give their recommendation. This case would be thrown out. The law firm wouldn't pick it up. This case is a joke in terms of the lawsuit itself. Now, with that being said, it would not be actually Dr. King giving her deposition, at least only Dr. King giving her deposition. It would actually be everybody attached to that case. Now, it's the attending's case. Dr. Robbie would actually be given a deposition as well, unless he already did. Right now, it appears that King is the only one on the PITT that they're portraying as given a deposition, but it's actually the attending's case. This is actually Dr. Robbie's case. Typically, in situations like this, the attending is doing his or her deposition. Sometimes not even the resident, and other times it's the attending first is given the deposition, and then the resident is giving their deposition. Now, I'm not even going to talk about giving depositions on holidays because I'm not a lawyer. That's outside of my expertise. I don't know when depositions can happen in terms of holiday, not holiday. Like, I assume they can happen at any time. I assume, as of you and me, that they can happen at any time, but it's a little outside of my scope of expertise, so I'm not going to talk about it. That's why I briefly wanted to mention the deposition, like this part. I'm not going to talk about it further depending on where they go, but I wanted to mention it here because the whole dynamic is a little bit weird. The only thing that would make this even worse, I'll critique this if it happens, but if they try to portray like the legal team coming into the ER for this, oh, I'll call that out every single time because that doesn't happen. I'm waiting for that one. But I just wanted to point out a few things regarding this deposition.
I have been training residents for years. You are one of the very best.
Him?
He's one of my favorites.
Promise.
Thanks.
She's not thinking. Okay?
It's gonna be great.
Then I'm taking her home. That's it.
We have to honor your wife's wishes.
Even if she's loaded up with morphine and can't think straight.
Especially then. Hello?
Paul Hamler. This is my attending, Dr. Rubinovich.
My wife is not thinking clearly.
What is it that she's asking for?
Said she wants to stay here.
Why don't we all go in and talk?
Brian Jenkins is allowed to hunt with a 22 on his grandpa's farm.
Sounds like an accident just waiting to happen.
And you're not Brian Jenkins.
How are we doing in here, Roxy?
And better?
Rumor has it you're still interested in booking a room with us.
I don't want to go back home yet.
It's all set up, Rox. You're gonna be more comfortable at home.
Oh, I changed my mind. It is our home. I don't want you living with my ghost.
I will happily live with your ghost.
Can we just all stop talking about ghosts, please?
Yes, I'm sorry. Sorry, sweetie, you're right.
Got trauma flying in, ETA 5 minutes.
Okay, I'm very sorry.
Trauma is flying in. We all know they're going to go to the helipad. It's going to be unrealistic.
It's a boating accident, swimmer versus propeller.
It would be nice if they didn't go to the helipad.
They didn't say.
How old?
Nope.
Anything?
All I got was boating accident, swimmer versus propeller.
Propeller. Got it.
You get more of a report than that. So we have a trauma flying in, boating, swimmer versus propeller. We don't know anything else in terms of body parts, age of the patient, which I'm calling now 100% unrealistic. That flight crew would have given at least a 1-minute report to the charge nurse on the case coming in. We just talked about that. We keep seeing these horrible reports, not just EMS reports, but this limited info of these big cases coming in. It is standard, and I mean it is standard protocol for either EMS to give a radio report prior to coming in or the flight team to give a report of the patient they're flying in. All these cases are not always mysteries like this. Let's bring in a mystery. We don't know what we're getting. We're getting a mystery. Like, that's not realistic. It doesn't happen. I see why they have to be like this. It's for the dramatics. Just know that in real life, we would have more information than what they're giving here. It's the part that makes it not realistic. Don't go to the helipad. Set up your room instead. It's ridiculous. They are going up to the helipad. Ugh. I've said this so many times. We do not go up to the helipad unless it's for a selfie. All right, and even some hospitals don't allow that, just saying. We don't go up there. It's for dramatic appeal. I've called this out throughout season 1. I'll continue to call it out through season 2 and 3 and however long it goes. This is a single attending ER. I don't care if there's residents or not. This is a single attending ER. Dr. Alashimi, okay, you say, oh, it's a 2 attending. This is a 1 attending ER. She's on orientation shift. But let's be honest, even if Dr. Alashimi wasn't here, this is still a 1 attending ER, and Dr. Robbie would still be out on the helipad. They did this in season 1 quite a bit. You are a 1 attending ER. If Dr. Robbie leaves the ER to go to the helipad, it's 100% not realistic. Now you just left your trauma center without an attending. So regardless of how many attendings you have, your only attending is not going to leave the ER and go to the helipad. That's crazy. For the flight team, you typically have a critical care nurse, a respiratory therapist, and a flight paramedic. They are so capable of bringing that patient from the helipad into the ER room. After all, they did just resuscitate that patient, fly that patient the entire distance, and landed them on the helipad. I think they can probably move that patient from the helipad to off the helipad. Typically, then it's on the elevator, down the elevator, and then move them into the ER. That is pretty normal. I think they can handle an elevator down to the ER. If you are going to the helipad and get report, you are doing nothing for that patient. You still have to return to the ER. You're not even set up for anything. That critical care team then has to give report again for that patient to the nurse caring for that patient. PITT, stop going to the helipad. This is crazy. Or at least come up with another reason to be up there. Stop going to the helipad. In a perfect situation, what normally happens in real life, you get a better report, you know what's coming in, trauma room is set up, you're ready to go. So let's say you're getting a 36-year-old boating accident, tourniquet to his leg, the other leg is missing. A leg actually shows up later. I've had that same patient. It wasn't a boating accident, it was a motorcycle accident, and the leg actually showed up like an hour later. They found it unseen off a ditch or something. And so anyway, the patient's coming in, tourniquets to the leg, the other leg is missing, they've got a flailed chest, they're intubated prior to arrival. With that report, we're set up for any chest tube. We're set up for a blood transfusion. We're ready. You know, the cordis is ready. As soon as that patient touches the trauma bay, boom, resuscitation. There is no delay. If you're on the helipad and you're going to take that patient like directly to the OR, sure, go to the helipad. That's not happening here. In the PITT, they're not going to go from helipad to the OR. It's not happening. Again, stop going to the helipad unless it's for an awesome selfie after shift. Otherwise, stop going to the helipad.
Picked a hell of a day to come back,
The time that could be spent prepping that room.
He's good.
This is awkward.
Gonna be a senior this fall. That's great.
Let's go out and listen to a report, and we can't do anything until they get in the room.
Yeah. Okay, I'm just gonna say it. I'm sorry. I betrayed your trust. I betrayed our patient's trust. And I'm really fucking sorry. It'll never happen again, I swear. I'm really glad that you got the help that you need.
These flight crews are so well equipped with resources, with staff. They can take care of this patient until they get in the room. See, I told you, Robbie and Langdon did nothing bringing them down from the helipad. They weren't assisting the team. Let's be honest. This entire critical care transport team, you guys are awesome. I know all my teams. You guys are terrific, and they're well equipped to bring that patient from the helipad all the way into the ER room. Dr. Robbie and Langdon did nothing bringing them down from the helipad. Sure, Robbie is bagging, but the team has been doing that like without him anyway for a while now. They don't need him to bag. We need to stop seeing this helipad drama. Now what you end up with is part of your team knows the story. The other part of the team does not know the story. The nurse assigned to this case still needs to get report. She doesn't know anything about it, or he doesn't know anything about it. Now the flight team has to give the exact report all over again. You can see the issue with this. You can see that potential delay in care.
Why'd you intubate? He was splinting from the pain. Barely moving air with sats in the 80s. How do you get sliced up in the propeller? He was in the Allegheny trying to untangle a water ski tow line when his buddy started the engine. Drunk buddy, I assume? It's 4th of July, you tell me. Focus on the patient, please. Sophie, take over bagging.
See, now you have to give the report again because nobody else heard it.
Okay. 1, 2, 3. Watch that buckle.
You need me in here?
Nope. We have a senior resident and an attending. Mel, can we start with a...
EFAS, sure.
Yes, please. Why?
To check and make sure there's no pneumothorax, otherwise it could become a tension.
Exactly. Oh. You want ONEG?
Now without a BP first.
108/64, pulse is 102, sats are good.
Okay, let's have ONEG ready, but don't give it just yet.
Anything else?
How about a hemocube?
Yeah, of course.
Our VRI isn't working. Video relay interpreter? Yeah, of course I rebooted it. Wait, how are you gonna fix it if you don't know what the hell it is? Yeah, okay, whatever. I wanna do a head and belly scan on Harlow. Can you try telling her why?
What about the VRI?
It's DOA.
So inappropriate. We have established you can communicate via writing. Then the resident is telling the nurse that she wants to do a head and abdomen CT scan. And for the nurse to communicate why. No, that's not the ER nurse's job. That's the physician's job. A nurse's job is not to tell the patient why they're getting a CT scan. No, that's the physician's job or that's just the physician being really bad. Either way, that's not the nurse. Like, that's not the nurse's job to tell a patient why they need a CT scan. Like, Santos, go talk to your patient. This is ridiculous. Now, I will say if the doctor explained the CT, planned for the CT, reasoned for the CT, ordered the CT, did all these things, and it still went above the patient's head, yes, the nurse can help clarify things, sure, but that's not what Santos is doing here. She wants the nurse to communicate everything. No, Santos, that's your job. If you're going to order the CT scan, you're going to explain to the patient why they're getting a CT scan. You're not just going to order it. I would hope that if one of my residents did this to an ER nurse, all right, I would hope that that ER nurse would come get me and let me know. Now, side note, in real life, with how long this patient has been in the ER, this would have already been staffed with an attending. If Santos was a good resident and staffed this, or at least what little info she had, the attending would step in this case and help out. In real life, there is not necessarily a timeline for staffing. I will say for second-year residents in general, you see a patient, orders, you're typically going to staff that probably within 20, 30 minutes, maybe an hour at the most, but not 7 hours. As an intern, you're typically not going to put orders in unless you've staffed it first. Second year can go both ways. When you get to be a third and fourth year, a lot of times you're putting orders in and imaging in, and you staff it when you can with the attending. It really depends on the attending, and it also depends on the resident's knowledge level and year in the program. No second year is going to wait 7 hours to staff this case. But overall, Santos is just a horrible resident. Horrible.
I'm charting every free minute I get. I wasn't coming over for that. Good job in the trauma earlier. What's this?
Okay, another EMS report. Fingers crossed.
32, weekend dizzy while washing his car. Tachy at 106, BP 90/60, temps too high to register.
We have a cooling room set up in North 5.
Okay, how you feeling, Mr. Scott?
Thirsty.
So we have a 32-year-old male that got weak and dizzy while washing his car. He's tachycardic at 106, 90/60, and temp is too high to register. Solid report, no complaints with that. I like that. When we hear that the temp is too high to register, the biggest thing we worry about this time with this history, this situation, this day, with what we already know, heat exhaustion and borderline heat stroke, especially these temps above 104 degrees. Patients with a heat stroke can be confused, they can be altered, they can have a seizure, they can quickly decompensate, like really fast. If they go with a heat stroke in this patient, which they should, because the last kid just had a heat exhaustion, at least what we know, it's only a heat exhaustion, not to mention what else he ends up having, or if that's the only thing he has. A heat stroke, on the other hand, is severe. It is life-threatening. It is the endpoint of a heat illness. Well, I guess the endpoint would be death, but heat stroke is like right before that. That's how close it's getting. It's a temp greater than 104, and you're gonna have some type of CNS dysfunction. Confusion, seizures, agitation, slurred speech, ataxic gait. Some patients are gonna have this like bizarre behavior. They come in temps 105 and they're just acting funny. That's a heat stroke, all right? You don't have to have a seizure for a heat stroke. Certain criteria equal heat stroke. And so, but these patients will end up with multi-system organ dysfunction because of the heat-induced systemic inflammatory response. It's bad. These patients can decompensate so fast, they come in 1 minute and then the next minute, boom, seizure. So the goal is to drop that temperature. We are immediately starting a cooling protocol. We're giving benzos like Ativan or Versed, and we're giving IV fluids. We are getting aggressive with it. I got a bad feeling about this case. Ooh, I just got goosebumps. So, when an ER doc gets goosebumps, you should be worried. This is that Gestalt type feeling. An ER doctor getting goosebumps, oh, something's gonna happen.
If we can't fix that, he's gonna need a core temp, a CMP. Whoa. Oh, hey, we need a trauma room. What's open? 2.
Now that's likely
I'll
a
grab
heat
the
stroke.
Ativan.
Any past medical history?
No, wife says he's healthy. No meds, no allergies.
He needs a core temp. Ready to transfer?
Let's give 2 of Ativan. Don't want him seizing again.
Okay, I mean, not bad. When a patient's actively seizing, sure, give Ativan, give a benzodiazepine. Now, I would have actually given Versed myself, but Ativan is just fine. Cooling is the priority in these cases. Every minute of delay in cooling that patient is going to increase their mortality. When we see these heat stroke patients, the goal is to decrease that temperature. Arctic sun and ice baths, I agree with. That's perfect. The Arctic sun is what I use. It's basically this targeted temperature management by circulating this chilled water literally in pads that are in direct contact with the patient's skin. It's going to drop that temperature. I will say there are a few things that we don't do for these patients, and I'll critique this if they go down this route. There are a few things that we don't give these patients. It's always fun to ask the med students, the interns, the residents on this to see what their response is and why, because it's counterintuitive. But there's a few things that we don't give. We actually don't give antipyretics in this case, like Tylenol. We don't give Tylenol. We don't give Motrin. You may be like, wait, the patient has a high temperature, doc. Why wouldn't you give Tylenol or Motrin? In heat exhaustion and heat stroke, it's different because in these patients, the hypothalamic thermoregulatory set point is actually normal. This is different than in sepsis. The brain is not increasing the temperature, but rather your cooling mechanisms are overwhelmed or fail. In a heat stroke, your body wants to have a normal temperature, much different than in sepsis, for example. These meds don't work for fever and heat-related illness. NSAIDs will not help the fever. If anything, it can actually worsen other issues, especially with this multi-system organ dysfunction that you can see. There are a few other things you don't give either. You don't give dantrolene. We typically avoid vasoconstricting medications like Levophed or Levophed, however you like to say that, for example, because that can actually redirect blood from the skin. It can impair cooling. We also want to avoid shivering. So if the patient starts to shiver, we actually give benzos for that. Like Ativan or Versed or something. The shivering becomes actually counterproductive to what we're trying to do. We don't want the patient to shiver in that situation. So those are the big meds that we don't give in heat stroke. So feel free to, any attendings watching or whatnot, residents watching, if you want to pimp one of the interns, be like, hey, what don't you give in a heat stroke? Tylenol, Motrin, dantrolene, certain vasoconstrictors, like mention these things that you don't give in a heat stroke.
1, 2, 3. Orders. Second IV was saline open, sepsis panel, UA, urine drug screen, EKG, and CK.
I don't see any apparent trauma.
Pupils reactive. Mr. Scott, Daniel, can you talk to me? Post-ictal, but moving all extremities.
Pulse 137, BP 88/60.
What are you thinking, Dr. Santos?
Heat stroke, but consider sepsis or
I mean, it's good. His temps can be really high, though. 104, 105.
Temp is 104.6.
Okay, let's start with 4 ice packs on the groin and axilla. Should we do a full body ice bath?
That'll take too long. You have an Arctic Sun?
Yeah, we do.
Get pads on the chest, abdomen, and both legs. I'll check back in.
Solid.
Ceftazidime is up, and first hemoglobin 8.2.
8's pretty low. He must have bled down from 14.
Anything you want to do about that?
Young, healthy guy, we transfuse at 7.
Do we? We'd be in real trouble if he equilibrates from acute blood loss.
Am I interrupting something?
Motor lacerations,
Jesus, this looks like some Jurassic Park shit.
Is that your official surgical diagnosis?
He is hemodynamically stable.
What else do we know?
Straight up Velociraptor.
Intubated in the field due to poor tidal volume. EFAS was negative for pneumothorax, so no need to do a chest tube. And no free fluid in the abdomen. Good hemostasis inside the wounds, nothing arterial.
At first, he had a hemoglobin of 8.2.
We'll follow that closely. With no active bleeding, I wouldn't transfuse just yet.
Dr. Langdon agrees with you.
Solid.
Let's get him to CT.
You can tell Robbie was pushing him in this situation, getting him to take charge. And I agree with Langdon in this case. With what we're told about the negative EFAS in a healthy patient with a hemoglobin of 8, you just trend it. I would not transfuse this patient at all. Now, you make this an 80-year-old on anticoagulation, positive fast. That's a different situation entirely. You get a hemoglobin of 8. It may not be caught up yet, and your repeat's even lower. This particular patient in the PITT, though, is definitely a patient I would trend the hemoglobin, meaning I would wait 30 minutes, an hour, sometimes less, and repeat it and see if it's stable. Just realize that also, depending on how much fluid you give the patient, that hemoglobin could drop as well, and so you have to take that into consideration.
62 was gathering the makings of a salad when he started feeling dizzy and nauseated, vomited once.
How you feeling, Mr. Stills?
I'm gonna die.
Well, you came to the right place to prevent that. Do you mind if I touch your abdomen?
Yeah, sure.
Does this hurt at all?
No.
He's tachycardic at 124 with a temp of 102.4.
Hey, Joy, what's your suggestion?
Get them into a room. That's
Dehydrated,
my
check
suggestion.
electrolytes, and move them to the cooling room.
Precisely. Good luck finding a parking spot.
North 5.
What? No valet?
The suggestion is to get him into a cooling room. With all these patients coming in today because of the heat, one of these is going to be something else. One of these is going to be something very bad. I will say in this case, they have not asked the rest of the history. The guy was gathering stuff for a salad when he started getting dizzy and he vomited. He's febrile 102 and he's tachycardic. Dr. Whitaker goes, like, right for the abdominal exam. How about you get the patient into a room? Your ER nurse gets report. You get that patient on a cardiac monitor. You start getting the rest of your history. You do your physical exam. You form your differential. Then ask the medical student, what do you want to order? They just assumed here this was all heat without completing any history, without completing any physical exam.
I have a surprise for you. Oh. Sorry.
It's okay.
Have you seen my patient? Orlando? Mr. Diaz?
Room was empty.
Seriously?
Yeah.
What happened to you?
Oh. Bullet grazed my vest.
You were shot?
Shot at. Geniuses thought today was the day to rob a goods warehouse. Didn't think about how long it would take to load the appliances. They panicked. All hell broke loose.
Jesus. Why do you do this?
My therapist said I needed a hobby.
Funny.
This is actually my hobby.
Shit, this sucks.
Oh, it's nothing.
No.
No, don't worry about me. I'm fine.
No.
Seriously.
My patient, he didn't have any insurance and he was already in a mountain of medical debt. He couldn't afford any of his meds.
It's in the bag.
Insulin, test strips, electrolyte powder. I got him everything he needed for home care.
So Uber to his house.
Is the hospital gonna pay for that?
I'll pay for it. What are you doing?
What you clearly can't. Did you make a chart?
No. This can stay off the books. Don't need the paperwork from the hospital or the police department.
Pretty custom to send the military literally everything.
secret.
All office visits, all records, everything is sent for everything that you do.
How's he doing? Any more seizures?
Nope. Temp 102.9.
Labs back? Mostly signs of dehydration, tad hypernatremic, mild BUN, and creatinine bump.
CK 400 something, nothing worse than that.
Okay, good. Keep cooling.
I'll monitor him.
Great. That'll give Dr. Santos a chance to get caught up.
Not even going to comment on the charts. I've exhausted it enough.
Your R2 year can be challenging. You just have to keep grinding. What's your dispo plan for Mr. Scott? ICU admission. You should call neurology to consult. Yeah, done.
So I actually disagree with calling neurology here. I will tell this to consulting physicians, to residents, and medical students. There is a difference, and I mean there is a difference, and I will stress this so many times, between a routine consult, between an urgent consult, and an emergent consult. In the ER, we will take care of the emergent consult. This heat stroke post-seizure needs admitted to the ICU. It needs admitted to the ICU team. The ICU can call neurology. There is nothing that neurology is emergently going to do for this patient besides, yep, we agree with cooling, benzos as needed. That's how those conversations go. Maybe Dr. Al-Hashimi, previous hospital, she called for consults all the time, left and right, because she doesn't know how to manage anything. But unless that consult, I want to be clear with this, unless that consult will change your management, we're not calling for routine consults. We are not calling for urgent consults. Last night I had a couple interns. I'm admitting a patient and it was, early morning, but admitting a patient and the resident will be like, hey, did you speak with so-and-so? Granted, I was in a mood, but I was like, I don't have a question for them. There's nothing emergently that they're going to do tonight. They need a routine consult in the morning. Oh, okay. And so sometimes if the interns want you to speak with the consult, like they're calling, they want you to speak with the consult, it's because then they don't have to. But that's part of their job. And so there's a difference between a routine consult, urgent consult, and emergent consult. In the emergency room, we will take care of your emergent consult. At the same time, we're going to take care of consults where the consulting physician's decision changes your management. That is the big thing with that. So please keep that in mind.
Since it was exertional heat illness in a young person, the mortality is low. But non-exertional heat stroke in an elderly person, you need to worry. I'll put in orders for repeat labs. Good work in there. This 49-year-old woman presents to the emergency department with the chief complaint of right ear pain. Hey, Donnie, can you do something about that?
What?
Seriously, that's not driving you nuts? The baby, it won't stop crying.
Oh, that music's my ears now. I think Jesse's the nurse.
Well, can't you... What the hell is going on?
With what?
With her. Can you make her stop crying?
She's been fed and changed. She's cranky from rhinovirus.
It's the emergency room. Come on, Santos.
Something you can do.
She's due for her next Tylenol. Give me a minute. I'll be right back.
Wait, no, I'm not gonna stay
In real
here.
life, that noise wouldn't bother us. We just zone it out.
problem?
We take care of the patient, but those are noises that just get zoned out.
That's precisely why I didn't go into peds. Okay.
It shouldn't be affecting her like that.
Hey, little Miss Sunshine. Is it time for you to take a little nap? That would be so fucking nice. Yes, it would. Starting to understand why you got left here.
So that's why we had to have her respond the previous way to get this. It just makes it unrealistic.
What's more from CT?
Nothing intrathoracic, nothing intra-abdominal. Propeller just missed gutting of it.
Very fortunate.
Repeat hemoglobin is 8. We're holding off on transfusing.
Plan?
I'll have Mel and Langdon suture up the lacerations.
Wait, what? That could take days. I can't
Calm
really-
down, Sadness. I'm kidding. This is one for my skilled surgical residents upstairs, not you Boy Scout butchers.
Boy, I missed you, Yo-Yo.
Can't say the same. Okay, let's take up this art project.
So, about before.
Back to it.
Good talk.
How we doing, Princess?
All right, a little bloated. I want too many hot dogs for the
Oh,
truck.
nice. She's got a sugar-free Red Bull. Personally,
You meant the
I
board,
like
huh?
Rise. That's actually what I have
Thus,
right
our
now.
incarcerated patient got a spot upstairs, looking for our unhoused patient Digby. And of course, we have Whitaker, Donahue, and the med students on these diversion intakes, but they just keep coming.
Yeah, we may need to start just sending people up and ask for forgiveness instead of permission.
Hello? Oh, okay. Yes, I will be right there. C-Suite wants to see me upstairs.
Called to the principal's office on your first day, not a good sign.
I think I'm a baby whisperer.
Hey, great. We'll add Baby Jane Doe to your patient load.
Forget I said anything.
Where are we with your deaf patient, Harlow?
The VRI was a bust, but the interpreter's on the way. Figured I'd just give her a head and belly scan and go from there.
No, wait for the interpreter. No need to give the patient unnecessary radiation. And your charting?
Catching up and checking it twice.
Good.
So I thought Dr. Robbie was actually going to get it right. This is that point to ask Santos, how you been communicating with this patient? We did see earlier she was able to communicate via writing. So continue that. At this point, stop delaying everything until the VRI or the translator arrives. That's crazy.
Hey, have you had a chance to speak to Langdon today?
No. Why, did he say something?
No, just curious. How is everything at home with you and Whitaker?
He's weirder than you'd expect. Yeah, but I don't see him all that much. He spends a lot of time at Amy's.
He has a girlfriend?
I don't know what to call it. The farmer who got burned last year, the day of the mass cache, his widow, Amy.
Oh, he died?
Yeah, he had burns on 90% of his body. His chance of survival was very slim.
Okay, so I'm an optimist.
The sun doesn't always come out tomorrow, Annie.
Wait, wasn't she pregnant?
No, she was a young orphan.
No, not Annie, Amy.
Yes, very pregnant and young.
And Whitaker's now seeing this Amy?
And her baby. He got really close to the family when the husband was dying. He really believed that the guy would pull through. He helped her through the loss of her husband, and then again when she had the kid, and now he spends almost every weekend at the farm.
Huh.
Plus he's on the street team, and he just wants to help everybody, and I just don't want to see him taken advantage of. You know, he's just a fucking huckleberry.
Yeah, but he's our fucking Huckleberry. I'll talk to him.
Hey, your call.
Strong deflection, well played.
You're the boss. Or you are until end of shift today.
Still the boss. When you see me in here, still the boss.
Copy that, boss.
Dr. Robbie, can I grab you for a second?
Yeah, sure, what's up?
Can't you order my wife to go home?
I'm sorry.
Nope, it's her wishes.
My wife's dying, and you're telling me there's nothing I can do.
Mr. Hamler, that's not...
No. There's got to be something. Please.
It may not seem like much, but right now you being here for her and respecting her wishes is the best thing that you can do for her. Supporting her and her choices
So good.
is the most remarkable gift that you can give her at this time.
The meds we have her on will help her pain. And she may get to a point where she feels well enough to go home.
Before my mom passed, she was on hospice, but she didn't want to go home either.
Give me 1 sec.
Okay, I'm gonna let you guys get acquainted. I will be right back.
No, that's not how that works.
I'm waiting for Dr. Mohan. Is she available?
I will try and find her for you, sir.
It's the guy in shorts.
Good.
Who's this?
That is hospital CEO Trent Norris. He's the big boss.
They don't come into the ER looking like this.
Nice outfit.
Hey, Rockstar, gather your staff, please.
Sure, anything you want to tell me first?
I will say CEOs don't just come into the ER in street clothes. Sure, go ahead and tell the medical director that's on to gather the staff, taking them away from patient care and an already understaffed and overcrowded ER. 100% unrealistic, and that's all the time that I'm going to waste on this particular scene. Sure, in this situation, it may be different. There's a meeting going on, something's happening, he comes in street clothes, but honestly, CEO is not going to come into the ER dressed like this. Also, it was Dr. Al-Hashimi's day one, her orientation shift. She's not the medical director. She does not know that department. She is new. She should not have gone up to see the CEO. And it's actually inappropriate. They shouldn't even have called her specifically. It's just a weird dynamic, and this wouldn't happen in real life. Dr. Robbie would have had that conversation, or at least both of them would have had that conversation together. Weird dynamic.
Hey, everybody, can you gather around, listen up for a moment, please?
Have your attention, everyone. The internal disaster at Westbridge has been identified as a cyber attack. And now Good Dominion Hospital has been hit as well. Their ambulances are being diverted over to St. Mary's, but we can expect more walk-ins and Westbridge diversions.
For how long?
We don't know how long. If the ransom is paid.
Ransom? Are we next?
Our IT protection system has blocked thousands of intrusion attempts in the hours since Westbridge was hit this morning, but IT believes we're still vulnerable. So we're going to preemptively shut down all the computer systems.
Well, you better take a picture of those screens.
Patient registration, electronic health records, lab and radiology interfaces, email, internet.
Talk to me first. You want to consult my department?
I consulted your fellow attending.
Ouch.
When are we going down?
Soon. Very soon.
Okay, hey, somebody get a picture of the board. Quickly, quickly. We're about to go analog.
Going down.
Phones work? They don't work.
I always hate when this happens.
You got the photo? Yeah, I got it.
This is going to be fun.
That concludes episode 7. If you have not checked out my other live reactions, please do so. I have a live reaction to Code Black Season 1, Episode 1, in addition to a live reaction to the Scrubs reboot that was released this year. I do have already recorded live reactions to the Season 1 episode of The Resident, in addition to the movie Code 3, but I'm really trying to get all the PITT critiques done first. My name is Dr. Taylor, and welcome to Dr. Taylor Reacts.